Super. Welcome everyone to what is IPPR and IPPR North's last event of Labour Conference 2022. So hence the wine and drinks. Please do help yourself as the moment takes you. We've got a great last panel here for you this evening with some late arriving guests who I will introduce as they come in. But we're here to discuss levelling up health and the role of our devolved authorities, our mayors, our local authority leaders in delivering improved healthy life expectancy. By means of a short introduction, I'm Zoe Billingham, I'm Director of IPPR North, and of course we focus on regional inequalities and levelling up. So for me, healthy life expectancy is perhaps the ultimate indicator of successful levelling up, and hence why we've collaborated tonight on this event. We're hosting it in partnership with the Health Foundation, so a big thanks to that partnership. Really delighted to be here with you. It's everyone's last chance, given it's our IPPR last event, it's everyone's last chance to be controversial, say what you think, ask what you like. So I really invite you to participate in the discussion once we've heard from our speakers. Just to let you know, we're also streaming live on YouTube, where there will be also a recording. So just before I introduce our panel, who are a mix of here and not here so far, I just wanted to give you a bit of context for today's discussion. So, of course, we're fresh from Labour Party conference announcements on health and care. We've heard announcements on reducing the involvement of private equity in social care, on the continuity of care with GPs, and of course the big announcements we heard from Rachel Reeves just earlier on the healthcare workforce. That's more nurses, doctors, and health visitors. And of course all of this is a really welcome focus, and especially hearing it from the Shadow Chancellor of the Exchequer, which we thought was a nice twist on traditional health announcements. But we also know that the NHS doesn't hold the levers to most of its demand, and indeed, I think the latest statistic on this is 80% of health outcomes are actually dependent on things outside of the NHS, and that's what we're here to focus on today, and how that interacts with local leadership, as I said, of mayors, metro mayors, and local authority leaders, and what we can do about it. We also know, of course, that healthy life expectancy has been stagnating in this country, and that's really a first in terms of not seeing improvements in that very important metric. And we have a 19-year gap between the best and worst performing local authorities in England, between Blackpool and Wokingham. So, you know, it couldn't be a more critical indicator of the success of what our economy is for, who's it serving, and where is it serving. We also know that following the COVID pandemic, we have what's been dubbed the sort of missing million additional people who have left the workforce since COVID, and we know 400,000 of those are out of the workforce due to health-related reasons. So this is both a moral issue, it's what's the economy for, and it's also an economic and workforce issue. So it couldn't be a more important debate to be part of. We do have two politicians joining us shortly. We will be hearing from Mayor Roxana Fiaz, who is the Mayor of Newham in England, in the south of England, I was going to say, in London. I'm the Director of IPPR North, give me credit for that. And then we'll be hearing from Metro Mayor Andy Burnham, who of course is the Metro Mayor of the Greater Manchester Combined Authority. But before we do that, I'm going to hand over to each of the two panellists who are here already. First, I will hand over to Jo Bibby, who is the Director of Health for the Health Foundation, before I hand over to IPPR's very own Chris Thomas, who's leading our Commission on Health and Prosperity. So, Jo, over to you.
Okay, thanks very much, Zoe. So yeah, hi, I'm Jo Bibby. I'm Director of Health at the Health Foundation, and the Health Foundation's an independent charity that funds research, policy work and practical work to look at how we can improve health and healthcare in the UK. I think whatever the Trust government brings, there's no question that there's still going to be a challenge to level up health. As Zoe sort of described, we know there's huge gaps in life expectancy across the UK. Recent analysis that we've done looking at when people become diagnosed with ill health shows that if you're a woman living in the poorest part of England, your level of burden of ill health at 60 is equivalent to a 76-year-old woman living in the richest part of the UK. So there's a big difference in how we experience health across the country. And poor health obviously limits our lives and what we can do with them, but they're also, an unhealthy nation is also a brake on the economy. So we have to look at this, as Zoe's saying, from sort of various different angles. And again, you know, we know that the NHS can't carry the burden alone. It's not there to fix all the problems of the rest of society. We have to get the building blocks in place so that people can have a healthy life and stay healthy for as long as possible. So what would this mean for a future Labour government? Now, there's good news and there's bad news, it seems to me. So starting with some of the good news. The good news is that under the last Labour government, health inequalities narrowed. So we narrowed the gap in terms of healthy life expectancy and life expectancy. And there's been a lot of analysis done of the policies and the implementation of those policies and what worked and what had impact. So for instance, John Ford, an academic at Cambridge, has published a lot of work looking at the policies, and he's identified one of the key factors for success for the health inequality strategy that New Labour implemented as being the redistribution of services, of resources and power towards poorer areas. And that was done in a range of different ways. It was done through regeneration projects, it was done through Sure Start, the minimum wage, changes to the tax and benefit system that was targeted at reducing child poverty. So a whole package of different measures did have impact, and that's clearly a positive. We know we don't have to live with this level of health inequality. We can do something about it. But there's also bad news. And I think this is in two respects in particular. First of all, there's a much greater challenge facing any government at the moment in terms of the nation's health. We've had a century of improvements in life expectancy, but they've started to stall, and for some people in some parts of the country, life expectancy is falling. And lots of factors behind this, but just to pick a few things out, if you look at obesity, obesity levels for children in year 6 in 2006 was 17%. In 2020, it's 25%. Obesity is a driver of all sorts of poor health. So this is a big change and a big burden that we have to address. The other challenge is going to be the economic context. Public spending is high. With an aging population, it will stay high. That's going to put limits on the choices and make choices harder between meeting the need here and now and investing for the future. I think the other thing is that despite the successes that Labour had with the health inequality strategy, some of them were driven by gains that were sort of things that were amenable to short-term change. So improvements in maternity care, for instance, improved infant mortality. But actually, there were things outside the strategy that ran counter to those goals. Things like, for instance, a failure to invest in social housing, the introduction of buy-to-let. We know that that has had an impact on affordable and good quality housing. Things like the changing in licensing laws has had effect on alcohol death and disease from caused by alcohol consumption. So these challenges mean that we have to look much more broadly. And again, we've got to look at the infrastructure. We have to say, how do we build an infrastructure that can support healthy lives? Now, I think this is where the good news comes in, again, is that the combined authorities that we now have across the various parts of the country actually provide an opportunity to think differently about how we support the infrastructure needed for healthy lives. And over the past 3 years, the Health Foundation's been working with 3 of the Metro Mayors, Greater Manchester, West Midlands and London, to look at the levers they have through housing, through employment, through green infrastructure, how those levers can be used to address health. Many of those things at an individual council level are much harder to change, but the convening power that combined authorities have mean that we can start to really tackle these things across regions. So in conclusion, we've got a major challenge in terms of health in this country and in terms of building a more equal nation. And if we don't have health, we won't have wealth. This is something we all know now. But devolution in the past 10 years in England has progressed rapidly. So I think a Labour government would need to ensure that it retains and strengthens the role of combined authorities in order to build a healthier nation.
Brilliant. Thanks so much, Joe. That was a really clear setting out of both the challenges and where you think there's room for us to develop. Roxana, firstly, welcome. Great to have you here. Shall I pass over to Chris before then we...
Yeah, whatever works for you.
We come to you.
Thank
Brilliant.
you very much.
Okay, so before I introduce Roxana again, I will hand over to Chris, our very own IPPR, Chris Thomas.
Brilliant. Hi, everyone. It's really good to see you, and thanks for joining us. It's now late in the conference season, isn't it? And we seem to have a poltergeist in the room with the lights, so I'll just acknowledge that.
I was going to call it.
A disco is much nicer, isn't
it? A positive
We've
spin.
got drinks, we've got disco. It's great. I'm head of IPPR's Commission on Health and Prosperity, so I'll start from that point. The commission that we've set up is designed really to do one thing predominantly, and that's to test its central thesis that if we have a fairer country, we have a healthier one, and if we have a healthier country, we have a more prosperous one. So to really take that chain, that linkage forward, and that makes this question of how we level up health and how we address some of the geographic disparities, inequalities that we know exist, that exist at grotesque levels, to be honest, across the country, an incredibly important, central part of the inquiry that we're going into. So I'll start with just some thoughts from initial commission findings. And one is really the double injustice that we see, the combination of economic and health injustice that we see across the country. In April, we put out research that looked into this, and to give an indication, so just one example, we pointed out the case of North East Lincolnshire, where people living there can expect to fall into poor health 8 years earlier than the UK average. But their output, the value of their output, is also, in terms of the productivity measures, it's also worth £8 less per hour. And we see this repeated across the country, this intersection of economic and health disadvantage. And what's really interesting, I think, is the relationship between the two, and how in solving one we can find ways to solve the other. So that's what we're really interested in. At the same time, if we think about the kind of policy train, so what's going on alongside that, I think we see probably some disempowerment, some actual reductions in the levers available to local leaders to address some of this. It's not the sum of everything that matters. It's a relatively small pot of funding for a set number of services, but one that always strikes me is the public health grant, and cuts that we've seen over the last 10 years now to the public health grant. In our latest analysis of it, we showed that the cuts are now edging towards around £1 billion, but also just the inequality within those cuts. If you're in the 10 most deprived parts of England, you'll have shouldered £1 in every £7 cut from that budget. If you're in the 10 least deprived, only £1 in every 45. So cuts to vitally important services, levers that local leaders have to address health inequality, but those are both being cut, and they're being cut in the places where they're most needed. So the train of direction is not necessarily where we want it to be. Why is that counterintuitive? Well, I think there are three key reasons. One is the human cost. I think we have to start with the moral and human argument for health. It enables us to live the kind of lives that we want to live, to see, children grow up, to engage in our communities, to do the things that make life worthwhile. But, and as Joe has said, a huge economic aspect to that as well. And only in the last quarter, we've seen yet again an increase in the role of long-term ill health in economic inactivity figures. You can't have prosperity without good health, so it's a real foundation. And the last one, I think the understated one, is just the role in better health and having the aspiration towards better, more equal health outcomes in better policy making. If it's at the heart of what we want to achieve as a country, if it's at the heart of what local leaders want to achieve in the places that they are working for, then it's very hard to cheat. If you do things that aren't progressive, health tends to get worse, inequalities tend to widen. If you do things that are progressive, health tends to get better, exactly because, as we've heard, so much of what determines health isn't just the NHS, it's everything else that goes around it. It's the social justice agenda. So what could we do? And I think there's a real opportunity here for imagination and to think very optimistically about the potential that stands in front of us. And I think we've seen huge potential in other places in, for example, the community wealth building agenda as an economic strategy, which has been put to hugely good use in several parts of the country to build more wealth and to keep that wealth locally and to challenge inequality and to empower places. Well, we have very little infrastructure to do similar and to bring the consideration of health into that framework. And something that we're very interested in the Commission on Health and Prosperity is understanding if we took that kind of approach, if we thought very carefully around what's the infrastructure that places need, that people need to own to have good health through the life course, if we think very carefully around work, jobs, employment, public services from a health perspective, then can we come up with maybe not community wealth building, but community health building, so something that's slightly more aspirational in that direction. We've also heard through the conference, and I was reflecting on the leader's speech today, an incredibly aspirational climate policy based on industrial strategy, thinking about the kind of expansion of renewable energy and the focus on innovation that was there today. While we have equally exciting prospects in health, whether that's public health innovation, whether that's through to biomedical innovation. So something that we can take forward as a progressive answer to many of the problems of stagnation and decline that we see and that Joe's pointed out already. So I hope that gives some provocation. I'll leave it there. I'm looking forward to hearing what others think and reflect on, but that probably gives a good introduction to the Commission from me.
Brilliant. Well, I think it's time to hand over to a politician now. So, Roxanne, if I may hand over to you as in your role as Mayor of Newham, what are the kind of things you're focused on in order to deliver improvements in healthy life expectancy for your residents?
Okay, so I'm going to ask you to go back in time, and I appreciate the time zone that I want you to go back to is probably a time zone that you don't want to go back to, but bear with me. If you go back in time to late April 2020, early May, it was actually 4 days to the day that I was due to be marking the end of my second year of my first 4-year term. And who would have thought, let alone a new leader of a not insignificant local authority. It's got a population of some 373,000 people, hyper diverse, 42 languages, dialects spoken, people with connections to every single country in the world, literally, but profound, scarring, sustained, enduring issues of poverty and inequality. And in those 4 days, prior to me marking the end of my second year of my first term, there was this screaming headline because all of us knew we were in the midst of the first lockdown, following from the announcement by the then Prime Minister in March 2020. From the outset, reflecting on the conversations I was having with the Chief Executive and the Director of Public Health at the time, and notwithstanding the Emergencies and Contingency Act 2004 that kicks in, which basically means the Chief Executive responsible for running the council. And I said, heck no, I'm still the mayor, and our mission is to save every single life. Whatever it is that we have to do, we have to save lives. And in that 4 days before, that point that marked the end of my second year of my first term, there was this screaming headline in The Guardian that pointed to Newham having one street in one of our neighbourhoods where 32 people had died because of COVID-19. And I literally cried. I was crying in my office with my Director of Public Health. And we had been embarking on an ambitious agenda around health justice and health equity, very much wrapped up in our community wealth building and inclusive economy strategy that my administration back in 2018 had set out as our intention for a community so full of diversity and everything that entails, both the beauty, the richness, but also the disproportionality. Because here's the thing about health justice. Yes, we do know that social determinants are key, and addressing social determinants, poverty, inequality, bad housing. But also, let's not forget disproportionality and actually the impact of key cohorts in our communities across different ethnicities, but also across different classes and ages, elderly people, disabled people, young people, those that live in intergenerational households, of which there are many in Newham. So what we have done as part of our response to COVID-19, you know, there was a big, massive feature in the FT about 4 months after those screaming headlines. I mean, as it so happens, The Guardian got the headline wrong, and it real disservice actually to the community, because I had to spend 3 months of actually reducing the trauma that the entirety of my community and my borough felt, having read those headlines in the midst of this global pandemic and crisis that we were all facing. But what we did as part of our COVID-19 response was across 8 missions, very much placing the health and well-being and happiness of our residents as the principal measure of our economic success. And as the Mayor of Newham, that also chairs our health and well-being board, which is a statutory body, we've been able to marshal the entirety of the health ecosystem locally. And I would say that in the context of, you know, health justice, health equity, levelling up, if you want to use that frame still, a regional approach actually doesn't work. And I tell you why. It's, you're covering too much of a large geographical landmass, and you have too much of a distance to what's happening on the ground as it is under the NHS London. I mean, badgering them to get them to think about this is how you need to do health equity and health justice with communities. Actually, you listen to them. We were the first local authority to deploy COVID-19 health champions that then got appropriated by national government and scaled up across the country. And it was predicated on a crisis emergency response that's ordinarily used in international relief efforts. And I remember reading an article about the floods in Florida as a consequence of the tropical storms, and how they were using an interface of community voices and influencers within each neighbourhood to pass and disseminate really important public health information. And I remember actually having a meeting with Professor Kevin Fenton and Jason Strelitz, our Director of Public Health, saying, why don't we appropriate this model? And there was born COVID-19 health champions, and we've used that to deploy the health champion model across a whole number of health inequity areas of work, health young champions to tackle the issue of childhood obesity, which remains rife. We've got terrible issues in terms of oral health, dental hygiene, as a consequence of the decimation of dentistry as part of our NHS, and also with regards to us hardwiring health justice as part of our COVID-19 recovery response, but also what we're doing now as part of our term 2, which is building a fairer Newham. Building a fairer Newham absolutely links and is framed by the moment Build Back Fairer, and making sure that health is, is hardwired into everything that we do. So the health, well-being and happiness being the principal metric that we use to progress and track our economic success. Fundamental to that is the health of our residents, and everything that we do as a local authority that spends £1.5 billion a year in, a local authority where we've got amongst the highest deprivation profiles anywhere in the country. In fact, I think we feature in the top 10 most deprived in some of our wards. There's a heck of a long way to go, but what we are doing, as mentioned, is marshalling the entirety of the health ecosystem in Newham. And we've had, Bart's NHS Trust, which, yes, covers Newham, but also several other local authorities as part of the integrated care system, embracing our inclusive economy strategy and community wealth building, because they recognise that those social determinants actually a major contributor to ill health and health inequality, and sort of novel approaches to social prescribing. So we've, as one of the manifesto pledges that I put back in May of this year, we'll launch our social prescribing pilot across the entirety of a neighbourhood, and then we'll roll that out across the borough. So exciting times ahead, and I think the work that you're contributing to through the Levelling Up around health and the missions that you've set out are really important contributions to the debate. And what I would end and conclude by is that health justice obviously is linked to social justice, because we understand the social determinants of ill health, and economic justice, but also climate justice. So in Newham, we have amongst the worst air quality character of any local authority in England. We have some 115 people die prematurely because of vehicle fumes, and 4,500 kids that are sent to hospital with severe respiratory conditions. And you know, it's part of the really important mission to approach placemaking and challenge a consumer consumption model whereby car use is the mantra, but actually we've got to shift and pivot towards healthy lifestyles and sustainable places to live and for children to grow up.
Thanks so much. Hi there, Andy. No, not at all. Thanks for joining. May I just come back to you, Roxana, just on, it's really great to hear that sort of healthy life expectancy and well-being, you know, are your ultimate indicators in Newham of a successful local place. How does that change in very practical terms how you deliver services or how you organise services below that in order to meet those goals as your ultimate indicators of a successful place?
Really good question. So bearing in mind the health, wellbeing and happiness metric was introduced as part of our COVID-19 towards the Better Newham recovery response to COVID-19. So that was published in July 2020, so we're 2 years in. We're an organisation, the 9th largest local authority in the country in terms of population size, 4,500 staff, to shift a culture and a mindset which, you know, pivots towards health as the lens that you apply, and then the practice of understanding actually the relevance of that and how that needs to inform the core decisions you make around how you spend your money, but most importantly, the practitioner response and how you deliver public services. So we're still going through that phase of learning and sharing best practice, but it's happening, and it's a really exciting time to be driving this. And then the other thing that's coupled with that in the Newham context, and this goes back to my point around disproportionality even within health inequity, if we talk genuinely about health justice, you know, bringing a 4,500 staff team up to speed with issues of not just health inequity and what that means in the context of our 50 Steps to a Healthier Newham, which has a place-based approach to a healthier Newham, which we were shortlisted for the local government awards a few months ago, is an organisation needing to understand how racism plays out in the health system. And it's pretty crushing actually when you begin to delve into the granular data that shows the disproportionality amongst Black Caribbeans, Black Africans and Bangladeshis, which was brought to sharp focus during COVID-19. And then the final thing that I would say, again, you know, in reference to sort of, devolved regional authorities and their approaches to this, let me leave you with an example of what hasn't worked. So 10 years ago, Newham was home to the London Olympics, 2012. There was a promise of legacy, housing, health, sport. We failed on the sporting legacy. We've really done sod all around health and levelling up. So I think 2012 and the promise of 2012 and the legacy that was pursued offers us some sultry lessons in terms of what we need to be pursuing and thinking about 10 years hence.
Yeah, brilliant. Thank you so much for that. May I welcome Metro Mayor Andy Burnham to the stage. Andy, so far we've been speaking, of course, about levelling up in health. Maybe healthy life expectancy is the ultimate success indicator of that. And we've heard about some of both the challenges and opportunities, but we're specifically interested in the sort of the bit that the NHS can't control.
Yeah.
And how, as a local leader, those bits, what can you do about that massive chunk of health outcomes that isn't dependent on the NHS? What are you doing in Greater Manchester?
Yeah, thanks, Zoe. Evening, everybody. It's a really testing question at the end of
yeah, welcome.
No, thank you.
We're on event 25, so we feel you.
No, but this is a different topic. I've not addressed this week.
Oh, wow.
I guess the way I could answer it is kind of going back to my time in the Department of Health. I was Health Secretary, as you may remember, February 2010, when I took receipt of Professor Sir Michael Marmot's groundbreaking report. I remember him coming into my office in the Department of Health, and in the way that Michael does, you know, he does it in his very kind of quiet, but sort of tells you straight. He says, "Here's my report, and none of what I'm recommending, none of it you can do from the Department of Health." And it was a really memorable conversation, because he was saying the things that move health are outside of the Department of Health. It's the best start in life, it's school readiness for early years, 0 to 4. It's people's homes, it's people's work that either builds health or doesn't build health if those things are not right. So, you know, I remember that conversation vividly. I often talk to him about it now. You know, it was kind of clear to me by that point of the Labour government that you can move health so much through health services. And we kind of had that narrative as a government in '97 that we could improve health through health services. And you can, to a degree, if you improve access to A&E and cancer waiting times. You can improve health through those things, but it can only take you so far. Yeah. And obviously you're kind of chasing ill health, aren't you, with that type of approach. And I kind of then I went into my time as Shadow Health Secretary. And just one other thing to add, I'd started to talk about social care on NHS terms in my time as Health Secretary, and I first put forward the idea of a national care service, because I was very much moving, my thinking was moving to it's the social that you need to kind of prioritise if you're to improve, you know, that in many ways is the thing that, you know, so if you had much better social care, you would dramatically reduce older people's time in hospital, and that's where I was kind of in that period, and whole person care was something I sort of pushed as Shadow Health Secretary. But then it kind of brings me to this role, and this role came up as Mayor of Greater Manchester, and I was kind of, you know, obviously aware that we had that first degree of health devolution as part of the deal. And I think in many ways, this role that I occupy now allows you to improve health more than the Health Secretary, or certainly for the population that I'm responsible for. Because if you are, well, you know this, but it just needs to be said again. If you're going to improve people's health, you do have to change people's homes. You have to change people's workplaces. You have to change their communities. You have to change the start in life that kids get. You have to join the dots, in other words, between all of those things. And you can do that as a mayor of a city region like this one, or the one I lead, where I have a degree of health devolution, in a way that you just can't from the Department of Health. So the way I always describe the difference between those two roles, Health Secretary and Mayor of Greater Manchester, as Health Secretary, you could see numbers but not names. But as Mayor of Greater Manchester, I can start with names, not numbers, and you can build up from the bottom. And actually that is a sort of, that does build health, actually. So pre-pandemic, we did a huge amount of work on school readiness and developing a sort of whole public services approach, all public services as one team around the child or around the individual. And that, I think, is something you can do from this role that you can't do from Whitehall because of the way the policy silos work. We did a huge amount of work on homelessness, And I got the health, one of my achievements, I think, in terms of health devolution was persuading the health service in Greater Manchester, who originally said to me that they shouldn't be funding beds in hostels because that wasn't what they did. I said, well, you fund beds in hospitals, why not beds in hostels as well? And they said, well, it's not what we do, that's not our department. And I said, well, hang on a minute, you're going to spend a lot of money on smoking cessation, rightly, and sort of anti-obesity drives, rightly, but you're going to walk past the health crisis that's sitting on the street outside my office, with people sleeping rough, and that's a catastrophic health crisis because of the damage that rough sleeping does to physical and mental health. And in the end, they kind of bought that, and to be fair to them, they bought in to our A Bed Every Night scheme, and they are still bought in, and they contribute a couple of £1 million a year to a scheme that costs about £6 million to run every year, and we have 600-ish beds every night in Greater Manchester for people who would otherwise be sleeping rough. And I could point to other things that we did, and we achieved a bigger reduction in smoking. We got more people physically active, higher than the national average. And I think it was because it was this whole place, whole community approach to supporting people, big emphasis on, I don't like the phrase social prescribing, but you know what it is, but more live well, more social intervention rather than medical intervention. So I suppose the thing I'm coming to is, and I wouldn't want to overclaim for it, but 5 years of health devolution in Greater Manchester, where you kind of start to take a health in all policies approach. I can see Lynn at the back of the room, who did a huge amount of work with us on a good employment charter for Greater Manchester, where we're asking employers to sign up to standards, and Steve's done the same here, and we're linking that now to public procurement. From the bottom up, we're improving people's work, and that builds health. It's a health in all policies approach, which you can run as a mayor, but you can't run ever as a minister. You can't, because you're trapped in one world, and you'd have to get complicated agreements with other ministers, and it wouldn't necessarily join the dots on the ground anyway. See, mayors can do that. I think devolution can move the dial on health inequalities in a way that roles at a national level will struggle. And I think that is backed up to some degree by a Health Foundation report that's going to be published this week on the first 5 years of health devolution in Greater Manchester. I think the conclusion, I don't want to call it incorrectly, but
Spoiler alert.
Sorry?
Spoiler alert.
Yeah, oh, sorry.
Yeah. No, go on.
Joe, is this your speech that I'm about to...
Well, it's not my work, it's my colleagues.
Your colleagues.
So that's fine.
Like.
Well, I will only give the headline, and I'll let you do more of the detail. But it does say, correct me if I'm wrong, that life expectancy in Greater Manchester in the 5 years of devolution has increased better than expected, faster than expected. And the biggest impact has been in the least affluent communities. Now, it's kind of modest, it's a straw in the wind, but there is something there, And with integrated care systems coming in, particularly where you have a mayoral combined authority around the same boundaries as those integrated care systems, I think that this is our best chance to join the dots, to create a kind of sense of one public services, the health in all policies approach. And for us, with Sir Richard Lees leading ours, with all of his years of experience in local government, I think we've got a real chance of breaking down that cultural divide between the NHS and local government, and really taking GM health devolution now to building on what we've done, but going much further and faster and deeper with it, which is what we intend to do. So I hope some of that's of interest. I'll hand back to you. Zoe.
Super, thank you. If I may just come back to you, Andy, on one or 2 points. I'm feeling a bit like up for asking slightly testy questions, so I hope that's your vibe too right now.
Yeah,
Good. Okay, watch out, everyone. So I'll come back to you before then I open it up to the floor, so please do think of what questions you'd like to ask our panellists. I suppose just picking up on your point around the healthcare in Greater Manchester helping with beds for hostels. Obviously, it used to be the Department of Health and Housing, so in that sense, those two things fit very well together. But where are the limits for you in what the healthcare system should be doing to help the other side of the coin, which is the demand on their services and the social problems in a place?
Personally, I think they have to think very differently. I think the health service is going to have to, there's a bit of a paradigm shift needed, which is it's going to have to think social first, I think, because we're just not going to be able to get everybody, even if we could get everybody into statutory, medical, clinical services. It wouldn't be fully what they need anyway. And I honestly think we're going to have to get ourselves in a mindset of informal, everyday support that is more about connection, combating loneliness, exercise, support of various kinds through what I would call, what we are calling a Live Well service in Greater Manchester. That, I think, is going to be almost the first offer, rather than making people just wait for a clinical service that may or may not really move them forward. So that would be my answer. I think, you know, the waiting times for mental health services, even if you could reduce them, you're just going to have to support people in a different way. And I always used to remark to GPs whenever I used to shadow GPs at times when I was shadow health secretary. I always used to say to them, the weirdest thing is your surgery as a GP is like my surgery as an MP. And the counsellors will know what I'm saying when I say that. You know, people were coming in with social problems, but they were probably lonely as well. And the only person they could find to talk to was the GP. And therefore the only solution that they would probably get would be medical, when actually probably it wasn't necessarily what they needed. They needed something different. And I just think that's the type of shift we need. Mental health is the 21st century health issue. I mean, we all know that now, don't we? And therefore, how do you build mental health? I think it's about offering different types of support for people which are more social in their character.
And that would be expanding the remit of the health system in order to do that.
Yeah, but I think this is, I don't know if this is a controversial statement to some people, but I actually think strangely that the reorganisation that's just been done, for those who want to use it, could give you the infrastructure for a one public services approach, where you've got a coming together. Well, we're certainly going to use it as that. So I mentioned Sir Richard Lees chairs the Integrated Care Board, but Mayor Paul Dennett, Mayor of Salford, is going to be chair of our Health and Care Integrated Care Partnership. So we're going to set the strategy for Richard's board, and I promise you it will be a Marmot strategy. You know, we will be tasking our Integrated Care Board with a Marmot-style strategy. And obviously the health service won't be able to pay for everything, but it will be pulling it out of its sort of traditional clinical, medical sort of mindset, and it will be moving them into the community, into the social, into the informal. And one thing I would say, I think this is something that really needs to be embraced. The biggest thing we could do to mobilise new resource for the health service in England would be to commission community and voluntary organisations, some of them very micro organisations, some bigger, commission them differently as long-term partners, i.e. core funding, support, to provide a range of support every day, as instant as a prescription for people who are seeking support. I think that they have to think, I don't know whether you agree from a Newham point of view, but you know what I mean when I say it. Not as this like, oh, we'll give you a bit of project funding for 3 months. No, they're there for the long haul with the NHS. Commission them differently so that they're always a sort of a delivery system with social interventions that might take the pressure off GPs and off hospitals.
Yeah, really pertinent point. And I mentioned earlier the COVID-19 Health Champions, which was born from health champions prior, in that immediate period prior to COVID-19. And actually hardwired into that is the long-term commissioning approach, albeit I hate the word commissioning because it's more of a collaboration in order to improve the health of a place, and it's also about capacity building and leverage and deploying them within the context of what we fashion as social prescribing in Newham. Could be anything from volunteering in one of our biodiversity projects by the Royal Docks, and how that lifts the human spirit. And you were asking, how does the lens of health, well-being and happiness get systemised within the organisation? And I said we're 2 years into our journey, but it's as broad as getting the team in housing services that have got multi-million-pound budgets around the estate garden, and how they can be using their purchasing power to improve the estate garden for community gardens. But also, the conversation I had with the team last week, we signed off our cultural strategy early this year, and I was over in France at Nantes, and how they've hardwired culture and art into their urban landscape and how that lifts the human spirit. And I was saying we should also use, you know, the budget envelope that you've got for improving our housing estate to help also deliver aspects of our cultural strategy, because that will help lift people's spirit, and it's, you know, links to what you're doing.
100%.
Jo, may I bring you in here? I think you've got some views on this.
Yeah, well, there's actually two things I kind of wanted to just pick up on. One on, I mean, this sort of question of what's best done local and what's best done regional. And I do think there's something about making sure the right strategies are happening at the right level. So all the things Roxana was describing around the response to COVID, and in fact, the Health Foundation funded a prize for the best council with the health inequality strategy, and Newham won that. And I think there's so many things that you absolutely need to have that local knowledge, that local insight, the local connections in order to do, to kind of reach communities and provide the right support. I think, though, that actually, if you're a council in London, you probably don't quite understand what it's like not to have had a regional infrastructure. And I was kind of hoping you were going to talk about buses, because, you know, transport...
I talk about buses.
No, I know.
I thought this was my one fringe where I didn't have to.
But because at the Health Foundation, we've done analysis on the impact of good transport infrastructure on health, and it makes a difference. And, you know, if you're in a part of the country where, you know, councils on their own can't really make that macro change around transport infrastructure. They can't make the macro change around enterprise zones and so on. So I do think this is where the kind of regional role is important. So I think the really critical thing is working out what happens at each level. That was kind of one thing.
Can I just say on that dead quick? Sorry, I'm clicking across you, but it's to back you up 100%. Philip Alston, I've got his name right, I think. He was the former UN Special Rapporteur, wasn't he, on poverty? Yeah. He did a report, strangely, on the impact of bus deregulation in England on health. Have you, this is the evidence base for everything that you said. He said it led to social isolation, you know, poor mental health, and it's all. But it's just. He did a study on it, and it was everything you've just said.
Exactly. The second thing, though, is on this point of kind of the, you know, the sort of wider well-being services and so on. I think we funded some work that the What Works Wellbeing Centre did, looking at wellbeing services as they're run through councils. And there was a kind of interesting thing that they found, and they found that if the wellbeing services in councils were kind of run maybe from leisure or kind of not public health essentially, they were much more capabilities, kind of sort of broader support, social support. If they were funded from public health or kind of NHS, they had a much more medical model. So I think one of the things around this kind of whole commissioning thing is making sure that we don't end up medicalising well-being, you know, by commissioning it through the NHS. We really need councils to be taking the lead on those things and thinking about how they build and support capabilities in communities.
Yeah, absolutely.
Brilliant. Thank you so much for those remarks and that discussion. I think we've got about 15 minutes now just to take some questions from the floor for our panellists. So I'll take them in threes. We've got Ollie and a roving mic. Can we have the lady with the red top here first, please? The lady in red. Oh, there's two ladies in red. Wow, what a mistake. Sorry, can we have... okay, the microphone's gone to the first lady in red, second lady in red.
Jenny Rathbone, I represent Cardiff Central in the Welsh Parliament, where we have devolved health, obviously. We're starting to roll out free school meals in all our primary schools, and that's helped expose some of the inadequate support that families have got in that weaning period to get into healthy eating habits. So I just wondered whether either Newham or Greater Manchester had managed to maintain free school meals, because I know a lot of councils have had to abandon that, and what you think it tells you about how we have a whole system approach to developing a much healthier eating habits in our population, given the horrendous rise in fast food litter as a result of the cost of living crisis, which is something I find very difficult to get my head around.
Brilliant. Thank you.
Hi, I'm Kadisha. I work with Cancer Research UK as a part of the public affairs team. We do a lot of work with local and Westminster stakeholders, metro mayors, councillors, and MPs. Andy mentioned earlier about the health in all policies approach. So at the moment, I know Greater Manchester has devolved powers for health, but that's not the same across all city regions. So I wanted to know, what are your views on other metro mayors without devolved powers for health? How can they implement whole systems approaches towards improving health in their city regions, although they don't have the funding or the statutory responsibilities for it?
Brilliant. And can we come to the gentleman at the front, please, for the third question of this round, and then I'll come back for another round after we've brought these to the panel.
Hi, my name is Ishmael from Mencap,
Yeah.
and it's good to see you all. My question is, I have worked for Mencap for 25 years, and in that time, we have seen lots of leaders make inequality for people with a learning disability. But the last Learning from Lives and Deaths review showed that almost half of the deaths people with a learning disability in 2021 were avoidable, and 6 out of 10 people died before their 65th birthday. What do you think needs to happen to make sure that people with a learning disability can live the long and healthy lives they deserve? Thank you.
Thank you very much for your question. That was 3 brilliant questions. So we had our first question about the importance of free school meals. We had a question which I'll come to Andy for about what can the other metro mayors do who haven't got the levers you have. An excellent question just there about what we can do to better support people with learning difficulties to prevent unfair health outcomes. Roxana, may I come to you first, and then maybe Chris, I'll come to you. I think the free school meals question was directly squarely at you, but perhaps you wanted to pick up our last question as well.
Yeah, so we've sustained for a prolonged period of time an annual £6 million investment in universal free school meals to every single nursery and primary school kid in Newham, regardless of background. I got a slight kick in about a year and a half ago when I began to explore how we can optimise that £6 million, because I'm becoming increasingly concerned about the growing number of secondary school kids that for whatever reasons aren't accessing the free school eligibility that they have, but are going to school hungry and are, have a propensity to be eating those really cheap fast food, 5 chicken wings for £1 with chips. It's going to be really hard for us to extend it out, but I'd like to, and I think we need to mobilise a national campaign for universal free school meals at primary level, and then begin to transition to the secondary age cohort, so that by way of background and landscape, right now in Newham we distribute 50 tonnes of food every single week to thousands of households. That 50 tonnes of food saves households some £150 of food costs a month. 30 tonnes of that food is drawn from surplus food that exists within the supply chain, and we've become FareShare's largest local authority partner, working in London specifically with the Felix project. The additional 20 tonnes of food is drawn from our work under the auspices of the Newham Food Alliance with our voluntary sector partnership. We want to expand and embed it and build an infrastructure around that that's also linked to healthy eating, equipping people with the skills of how to cook and create beautiful meals with pretty basic produce. I think we've got to be quite visionary around how we incubate our own food supply ecosystems in our localities, notwithstanding our weather, seasonal foods. And then just quickly, in relation to the fast food piece or element, We've got a London-wide approach in terms of banning advertising on London Underground, Transport for London, and there's things that we can be doing at a local level as a unitary authority. And then the other thing that we can do is leverage our power under local planning powers to stop free fast food restaurants, because they mushroom around schools for obvious reasons.
And Roxanne, if I may, coming to our third question about those with learning difficulties, I know you were speaking very passionately earlier about how actually there's the place aspect, but also we can break down the types of people who will have worse health outcomes. How do we help address this?
Okay, so sorry, I'm pausing because I'm reflecting on the situation in Newham and the experience of those young people and children, including those transitioning into adulthood, has been pretty appalling in terms of accessing mental health and wellbeing support, outside of CAMS being absolutely under-resourced and overstretched in a place like Newham, where we have an upward trajectory of young people with special educational needs, and a large number of those languishing, waiting for their EHCP plans. I have to confess, despite a policy direction that we've got to sort out our special educational needs provision, and as part of my cleaning up the council and remedying the criminal disinvestment in children's services, SEND has been one that's really been squeezed, and we got an inadequate rating. But that's as much about the inefficacies of the health partnership that we work with on aspects of the EHCP plans, and just trying to access the mental health support for young people as well as adults with special educational needs really needs to be examined further.
Brilliant, thank you. Chris, I think you wanted to come in briefly on the health and all policies, and then I'm going to throw that over to Andy, because we had a direct challenge as to what Andy's Metro Mayor colleagues can be doing.
Yeah, absolutely. So, I wanted to come across from the and quickly touch on the nutrition question, just because we have some research recently which looks at the international context. One of the things that is hugely interesting, I think, is where countries have transformed their fortunes, and one of those countries is Japan. We now so commonly associate Japan with great health that it's strange to think that in the 1960s they were the G7 country that was the least long-lived, and that transformation has just been remarkable. The thing that was at the absolute core of that transformation was nutrition policy. It was free school meals. It wasn't just the availability of those, it was the quality, it was the nutritional balance. So it was a slightly more nuanced policy as well. The other thing that's remarkable about their transformation that makes us think lots to learn there is that the levels of inequality are just significantly lower if we take it as a geographical inequality, so the variation much lower. So I think there's an interesting context there, but also an example of what's possible, that there is possibility there. In terms of the whole system approach, I think it's an incredibly difficult question. There's huge variation in the levers that are available, and kind of direct control over healthcare services as well. I think integrated care systems do offer potential. I think what we've particularly seen in our work on integrated care systems is that there are some core things that really support that. How strong the community infrastructure is, what the relationships look like, the level of deprivation in a place going in. We have interesting and reassuring evidence from Greater Manchester, Annie, which is the most the place that most outperforms what you'd expect from their integrated care system outcomes, based on the level of deprivation and the inputs. So some really interesting things there. But I think the key is, from this conversation, I think the core message that's coming out is that the variety of levers that can improve health are much broader than we often come into these conversations thinking. So whilst there's a continue the devolution question to go, there's probably a question of the resources that get put behind that from the centre in the national context. I think there are lots of levers that we're implicating here that can be pulled at the place level that sometimes aren't seen in the health context.
Brilliant, thank you. And Andy, what can your fellow Metro mayors be doing to put health in all policies, even if they don't have the levers you have?
I just picking up on what Chris was saying, I think the infrastructure is kind of there now for people to do something with, and don't wait for permission is the first thing I would say to them. There's a lot you can do to build an integrated place-based approach to public services yourselves without any permission from Whitehall. And don't pull back from it is what I would say. I was with George Osborne last week, and he was describing the time when he signed the first devolution deal on health with Sir Richard and the other leaders at the time. And he was saying it was offered to a number of other cities. London it was offered to, and everyone said no, because they, oh no, health is a bit too... And I would say don't do that. Don't pull back, lean in, you know, definitely. Because for our experience is definitely not perfect. And on the constitutional standards, as they're called, you know, A&E, and I don't think we have seen movement there that we would have wanted to. But we, as you know, as we've described tonight, there is change going on at that kind of more health, population health level. So I would say lean into it. And I think, I like to think actually the ICS reform is a reflection of some of what we did with what we've had in Greater Manchester. I chair a reform board in Greater Manchester, which is a regular gathering of all public services and the community and voluntary sector, actually, and people with lived experience. And we often take a theme like homelessness, school readiness, or addiction, as we did recently, or life readiness of teenagers. And what we do is we have that whole system conversation. And then we take some of those findings into a reform executive we've got. And in time now, as the new health system, we'll be taking those calls into the ICS. So it's, and often I've done that without having permission to do it. You know, the DWP turn up because they can see it's an important conversation. They want to be involved. And the DWP in Greater Manchester has been great, actually, at sort of buying into our agenda. Or another example would be probation. When we were trying to work on homelessness, I was saying to the probation service, who weren't at the time part of our devolution agreement, I said, I'm getting worried about the number of people I'm meeting who are straight out of Strangeways and are sitting on Market Street under the covered area there. You know, that just can't be right. And to be fair, there's a great fellow called Chris Edwards who was leading Greater Manchester Probation. It was coming out of that grayling reform, if you remember that grayling. The grayling touch on probation was a, you know, was a kind of interesting thing. Well, not a disastrous thing, I should say. And Chris started to say, okay, well, there's something we can do here. And they started to sort of play in when there was no devolved agreement, but they started to, and then it's become a devolved agreement. We've got now a devolved partnership with Greater Manchester Probation, and they fund a bed every night, as well as the health service at a lower level. But that, so I would say to everybody, don't, oh, we've not got an agreement, no, don't do that. Get into that room of that ICS. Yeah. And the key for me is this, and we have to do a hands up here in terms of what the Labour government that did a lot for health but got wrong. We fostered too much of an institutional focus in the system, and that was a bad legacy, to be honest, that was left behind. And it was you can see that legacy across all public services, can't you? Colleges have been told to behave like that. The voluntary sector has been asked to be competitive, bidding for funds against each other, and I think you've got to again, like, you know, a paradigm shift from medical to social, but there's another one from sort of institutional working to whole system working. And I can see the beginnings of that in Greater Manchester. People are kind of leaving the institutional loyalties behind a little bit and are starting to sort of accept that this is a system that they're working in. And that can be done anywhere else, and it doesn't require a big blessing that you've got health devolution. The budget that will be being used by the ICS to commission the ICB will be similar to what we've got. We might have a bit extra to play with and more knowledge to play with, but that would be my thing. And if I could just answer the question, the brilliant question that you asked, that's an injustice, isn't it, that you just described, a terrible injustice. That those lives of those people are not what they should be. My answer to it would be, I do believe passionately, and I'll keep arguing for it, social care should be provided on NHS terms for adults with disabilities as well as older people throughout their lives. And if you had no care charges and you just had a complete support system that was about maximising independent living, that's what I would say is the answer to that. And we don't have that, of course, and we have an appalling employment rate amongst adults with learning disabilities, don't we? And you know, that, if you had a different approach to the way care is offered to people, as I say, everyone should get the care that they need to live their life. Simple as that.
Yeah.
And that's what I would say in response to that.
Thank you, Andy. That was really comprehensive. Thank you. I think, Joe, I'm going to bring you in before. I think we're going to have to draw to a close, so let me know if there are burning questions there. If not, maybe some of our panellists will be lurking at the back. Do you want to just state your question, just so I can wrap it in, and then I'll come to you, Joe? And yes, please.
I'm Vice Chair of the Health Scrutiny Committee in London Borough of Barnet.
Right.
And to narrow my question down,
Yes.
I wanted to know how we can better link health scrutiny with what you've all been saying, and would a incoming Labour government hopefully look at the role of health scrutiny and try, because at the moment we look at, reports from the Royal Free Hospital. Yes, fine, we need to do that, but I'd like to widen it out, and I'd like to know your views. Thank you.
Thank you very much for your question. Andy, I think you're just on the cusp of... What's your message? What's your message for the next Labour government, which, of course, you'll be closely tied to?
It's on the way, isn't it? And that's the great thing about this week, isn't it? And I think we're in a position, I think that the things that we've been doing as Labour mayors might help an incoming Labour government. And Wes Streeting is talking about a national care service, isn't he? So there's lots of promising things here. I think the answer to your question around scrutiny, it's the Integrated Care Partnership Board, isn't it, that sits above the system. That's, I don't know, Roxanne, you might want to say, are you on yours, by the way? I mean,
yeah.
So would you agree that that's where more meaningful scrutiny could take place?
Absolutely. So the scrutiny teeth there, and also obviously the role of additional member oversight through the local authority scrutiny system, and that still will remain valuable, and also the Health and Wellbeing Board at a local level. So all three interface with each other.
Thank you, Andy. Thank you, Andy, for your time. Yeah.
Thank you.
May I just come to Joe, because I know, sorry, we were juggling there between the two of you. What would you like to come on in before we draw to a close?
It was just coming back to the sort of what Metro mayors can do if they don't have the health and social care devolution, which obviously only Greater Manchester has. And the piece of work that we've been funding at the Health Foundation, one of the things we've done is review what the devolved powers of the different 10 Metro Mayor regions are. And I've just pulled the table up. And I think one of the interesting things is they all have responsibility for business and economic growth, which kind of goes back to the whole premise around health and prosperity. So that's absolutely a lever that can be used to think about health. But the other one that they have, I'm just looking at, which we haven't really talked about much, is adult education and skills. And I think, we just know, don't we, that there is so much to do in terms of equipping people to get into good jobs, the right jobs, jobs that can kind of give them a reward, but jobs that can support the economy. And I think that's a really important lever that Metro mayors have.
Brilliant. No, thank you for that. That really brings clarity to the debate and over the levers that they have. I'm going to come to you both now for final words. Chris, what's your message? Labour has had a very optimistic conference, it feels like. So what would you like to see a Labour government doing to ensure we're actually improving healthy life expectancy and levelling up the country?
Yeah, I think there are two really unifying and exciting narratives available to Labour in their thought process. I think the seeds of one have been sown by NHS policy in this conference featuring as economic policy, but it's the thought process that puts the idea of good health as a foundation to the economy. And I think we're increasingly seeing from COVID, but before it, that is vital. So having that chain of logic and carrying it through to its full conclusion, which goes beyond the NHS, but includes it, is fundamental. I think there's another one, which is the wider shift, the kind of drawing on Andy's shift to social that we've heard about. And I think there's one that even includes the NHS and that model a little bit more clearly, which is that we're moving to a paradigm where we need to think less about how we intervene every so often when someone comes in a paternalistic way as a fix, and more to one where we build the conditions for healthy lives. And that can be primary prevention by intervening early, the hostel beds that Andy was talking about. That can be making sure that the clinical treatments that are there are also adapted to that to empower and encourage and support good lives. So unifying messages that I think can be a paradigm shift basically for the health of the country.
Super. And Roxanne, very final thought from you. What do you want a Labour government to be hearing from local leaders as to how local leaders can play a role in improving healthy life expectancy?
I'd like for it to understand that it needs to move beyond hearing. It needs to go out in the field and see and help endorse and enable and empower even further local authorities within their community and partnership context, including within sort of, you know, the reformed NHS structures with these ISS integrated care systems, and the point that Andy made around, you know, lean into those and use them as your platform for driving through that paradigm shift. And I guess I just want to conclude the urgency of doing all of that, i.e. moving beyond hearing, is so evident across so many different parts of our country. And in the context of Newham, just as a reflective thought, as part of our research into the health inequality in Newham and why we've adopted this place-based approach, what we found is that for a young child, female of colour, born in 2018, will have a life expectancy that's 5.5 years shorter than their white counterparts. And for a young black boy, born in 2018, the life expectancy was 3.5 years shorter than their white counterparts. So, you know, the urgency of what we're doing is so evident and so urgently needed now.
Absolutely. Well, if that wasn't the rallying cry we wanted to leave us all on tonight, I'd like to say a massive thank you to our panellists and our co-hosts tonight, the Health Foundation, and Roxana and Chris. So if you'd like to join me in thanking our panellists. Also, as I mentioned, this is our closing session of the IPPR and IPPR North series of events, this conference. So if you'd like to join us for a drink to celebrate your time here, and with a huge thanks to Ollie and Holly, who have been arranging 25 events for us over the course of 3 short days. So massive well done, and thank you. And if any of you would like to pick up any of the work with the commission we've got ongoing with IPPR, please do grab Chris, so I point them in your direction, and please do join us at the back now. Thank you.